You're still on there. Why don't you go ahead and take out of this chair out of here? Thank you. Mr. Nash.
Thank you, Judge. I left off with Ryan Hayes, and again, I have the portion of your report up there. But I wrote down, you indicate in your report, do you not, quote, there is no pain to treat. Did you see where you wrote that?
Yeah, and I based that on number 3 above.
Okay, so just showing you what's been marked.
The patient was not moving, etc.
But again, you reviewed the medical records in this case, correct?
Yes.
I want to go over what's been marked as Joint Exhibit 2, pages 403 to 402 to 403. Fair to say that this is a medical administration record for Ryan Hayes.
Right.
Okay. And as part of your review in this case, you looked through Ryan Hayes' file and you saw this document, did you not, from 4/3/2017?
Yes.
So I want to go through it with you on the heels of your statement that there was no pain to treat. It looks as if, does it not, that the fentanyl is given, and at the time the fentanyl is administered, the nurse has indicated a pain score of 10, correct?
Yes.
And I understand your testimony regarding a 10. I just am questioning what the record says. And the time at which the fentanyl is administered is what?
The 22:57.
Would you agree with me that there is a assessment done approximately 15 minutes later as to whether the fentanyl has relieved the pain with medication? Do you see that?
Yes.
And what is written there?
No.
So that's approximately 15 minutes after the 1,000 micrograms of fentanyl is administered to Ryan Hayes. Nurse Tyler Springer indicates that pain is not relieved. Correct?
Correct, but the other records indicate something different.
Okay, hold on.
Doctor, let's take it into your work in the ICU. When you walk up to a patient, do you want to know 20% about that patient? Or 60%? Or if possible, would you like to know 100%?
All of it.
Okay. So that's why I'm asking you about the MARS. That was in the records you reviewed, correct?
Right, but they don't make sense in accordance with the rest of the documentation. That's why I want to know the 100%. I got to have the whole picture.
You don't.
And again, maybe I should ask this for every patient. You weren't there on 4/3/2017, correct?
No, I have to go by what the nurses tell me.
And so I want to talk about what the nurses are saying and telling you through the medical information they entered into the MARS.
Right.
So let's go back to it.
Okay.
Because wouldn't you agree that when a nurse enters in information, that nurse is speaking through that medical entry?
Yes.
So what Tyler Springer is telling you as to 4/3/2007 is that the 1,000 micrograms of fentanyl did not relieve the medication. That's what Tyler Springer is saying, correct?
That's what's documented there, but the rest of the records don't support that.
And then, next page, Tyler Springer has also indicated, has he not, there's another assessment for the Dilaudid, separate assessment. Would you agree with me on that?
Right.
And as to whether the Dilaudid has relieved the pain, it is indicated in the medical record the answer of no.
Unfortunately.
Is it unfortunate because it contradicts your testimony on direct?
No, I think it contradicts their own documentation in the other areas of the record.
In the ICU where you work, when a nurse, independent of you, goes to a machine, a monitor, and puts information to an EMR, right, electronic medical record, do you come from a place of distrust with your nurses, or do you come from a place of trust?
A place of seeking the truth.
And that's seeking the truth.
Yes.
So let's go here. You would agree that it indicates that it says a no as to whether the pain was relieved, correct?
That's what the paper says.
Okay. And it was after those notations made by nurses, a nurse, that the additional 1,000 micrograms was ordered. Is that correct?
Correct.
And noted there, when the second 1,000 is ordered, is that the pain score is a 10. Would you agree with me on that?
Yes.
And again, the 10 is reiterated, correct?
Yes.
You know, I left this out, but I want to make note of it. Those entries that I just asked you about were from Nurse Springer, correct?
Correct.
You would agree, though, that the initial pain scores noted up here are by Nurse Redmond.
Yes.
And this is Ryan Hayes,
Yes.
the medical administration record.
Yes.
You realize, because you've reviewed all of these patient files, that at the end of every patient file is a discharge summary, correct?
Yes.
And the discharge summary is done by the attending physician for every one of these 14 patients.
Yes.
And fair to say that Dr. Husel was not the attending physician for any one of these patients.
That's right.
And in your practice and experience, fair to say that the attending physician in its discharge summary reviews and summarizes what has happened to the patient before the expiration of their life.
That's the ideal. That's what you're hoping happens.
And then they sign off on the discharge summary.
Yes.
Showing you what's been marked as Joint Exhibit 2. Page 9. Does this appear to be a discharge summary for patient Ryan Hayes?
Yes.
And it appears, does it not, that the document is electronically signed by the attending physician?
Yes.
Correct?
Correct.
And discharge information is included right here, and it lists the number of physicians that had interactions with the patient.
Correct.
And if we could, the final diagnosis is listed, and then a brief summary. Would you agree with me on that?
Yes.
And the time of when the person expired is included at the very end.
Right.
Okay. I know I asked you about whether you had an opportunity to review the autopsy report as to Ryan Hayes. I forgot to mention, an autopsy report is done by a forensic pathologist.
Yes.
And based on your experience and training, part of a forensic pathologist's job, is it not, is to perform an autopsy and, if possible, determine the cause of death.
Correct. But
Okay. You answered the question.
And just so I'm clear, you were never provided the autopsy report with respect to Ryan Hayes in this case from the forensic pathologist.
That's right.
Different question, were you provided the death certificate with respect to Ryan Hayes as of the cause of death?
I believe I was, and I realized that it wouldn't say fentanyl overdose.
Okay, let me show you the death certificate. Showing the witness was marked as defendant's exhibit RH2. Does this look familiar?
Yes.
And this at the top, fair to say certificate of death?
Yes.
And I just want to make sure that now that you indicated you've seen this, you must remember then that the cause of death is listed as acute mixed drug carfentanil, fentanyl, morphine, and ethanol toxicity. Correct?
Yes.
And again, you're not sure what carfentanil is.
Well, I know I said earlier that it's a kissing cousin of fentanyl as well, and it's very appropriate for the medical examiner to list all those medications because they were all exposures in this patient's clinical course. We want to be very comprehensive in filling out death certificates, and I fill these death certificates out all the time, and we're taught to be as broad as you can to encapsulate as much of the likely path towards death as possible. It does not indicate a single cause, such as the drug that precipitated the actual death. That would never appear on a death certificate.
But my question was, had you seen it? And you had. Correct?
Yes.
And you didn't indicate in your report that the death certificate says that actually the individual consumed all of those drugs. And it does use the word consumed, does it not?
Right, and because my report was focusing on what was the proximate cause of his death.
Right, but we want the truth.
That is the truth.
Okay.
That's what I was seeking.
Let's talk about the next patient. Beverly Schertzringer. This was a patient, again, your report's on their screen, but she had a blood clot. Then she had a CT scan, did she not, which revealed this mass on her lung.
Right.
And it turned out that the lung cancer was later assessed to be stage 4. Correct?
Yep.
And then she had this biopsy within Mount Carmel West. And as a result of that operation or that procedure, she had massive internal bleeding.
Correct.
And that's how we find her to get to the ICU.
Yes.
Okay. And she's actually intubated before she even gets to the ICU, right?
Right.
And you would agree that in your report, you don't really talk about the massive internal bleeding. If you go to paragraph 1, you just indicate until undergoing a biopsy and ultimate transfer to the ICU.
I think it's a very accurate representation of what happened. Developed internal bleeding that led to an ICU stay. That's got to be massive.
I want to talk about, do you include in your report all of the other critical illnesses that she had other than just the stage 4 lung cancer? Do you include her atrial fibrillation, the fact that she had aortic valve stenosis? Do you indicate in your report that she'd been a chronic smoker since she was 15?
No, those are not indicated there. That's a good point.
But based on your review of the record, you would have to agree with me that those issues include, and also kidney failure, that she doesn't come to Mount Carmel West in 17 as a healthy individual.
I think you're making a great point. Yeah, she's even more vulnerable than the report indicates.
In paragraph 2, you indicate the patient initially received fluids but no other curative treatments were performed or initiated. Do you see that?
Yes.
Okay. And in your report with respect to Ms. Belisari, you used the term aggressive support measures. Here you're using curative treatments. What's the difference?
Aggressive support just means that I'm willing to take on things like a ventilator or vasopressors, antibiotics, that sort of thing. A curative procedure would be something, as in the case of a cancer, where we actually either get surgery to remove the cancer or some form of chemotherapy, et cetera. Of course, she couldn't have had any of that. It's not negligent that she didn't get it. I was just including it in the report. And the main reason I included it was because that was still on the horizon for her.
You would agree with me that after getting vasopressors 3 times, her blood pressure was 38/21. Correct?
Correct.
Tell the jurors, when my blood pressure is at 38/21, what's my state?
She is in shock, and in addition to that, it indicates she was in no distress at this time.
That's not my question.
I didn't know my finger would do that, sorry. No distress, heart rate, respiratory vitals, not an issue. So she actually was having vital sign issues with the low blood pressure, and I was trying to calculate whether or not she clinically would require those high doses of fentanyl.
Okay.
Because she was a vulnerable patient. I don't know if you can remove those blue dots, but sorry.
I'm going to take ownership of this again. I'm just ask you more succinct questions, because my questions are different from those that were asked for P1 direct.
Okay.
Because I'm asking you, my blood pressure, Diane Menashe, is 38/21. What's my state?
You're in shock.
Tell me where, and near death.
Anybody in shock is at risk for death.
Tell me where, in this report, do you include 38/21?
It's not included.
But yet you say she hasn't received chemo as a curative measure or had surgery on the tumor.
Right.
38/21, I'm not surviving a
Oh, no.
surgery.
No, you're not going to do the surgery then. The idea is, could she, if we get her out of the shock, undergo subsequent therapy to give her months to live with her family?
And then you testified, and I wrote it down, that she was opioid naive, and it's indicated in your report as opiate, but I'm just going to go to opioid. Tramadol is an opioid, right?
Non-opioid.
It's a non-opioid.
Tramadol is, well, why do you ask?
Well, no, you don't get that.
Okay.
You want to catch your flight?
Yeah, good point.
Let's answer her question.
Because here's my question, and not an answer. You reviewed the records, and so you know that she was regularly taking Tramadol.
Yes.
Right?
Yes.
But you testified to this jury that she's opiate naive.
So corrected. Thank you.
Showing you what's been marked as Defendant's Exhibit Ely 14. Does this look familiar? Let me try and clear that.
Touch the bottom left-hand corner, that'll get rid of those, of the screen above you.
itself, the bottom. No.
Up here.
No,
I got it.
screen.
I got it.
Okay, got it. Yep, as we learned.
There you
Okay,
go.
thank you. Showing you what's been marked as Defendant's Exhibit Ely 14. Tell the jury what patient this code sheet appears to belong to.
This is Beverly Sertzinger.
And again, this is a code sheet, is it not?
Yes, documenting that she's in PEA.
Code sheet, cardiac arrest, actively dying. correct?
Yes.
And it indicates up here that she survived this incident when she coded. Is that right?
Right. You can see ROSC below PEA.
And I just want to draw your attention. Does it appear that this column is the time of the arrest?
Yes.
Okay. And the physician's signature, does it not indicate William Husel?
Yes, it does.
So William Husel is in the room when this patient is coding, saving her life?
Yes.
With respect to Beverly Shirt's thing, 3 questions. First question. Fair to say that you are unable, as you sit here today, to a reasonable degree of medical certainty, to say, but for the dose of fentanyl, when she would have died?
I cannot say when she would have died, but for the dose of fentanyl.
And based on your review of her medical records, you cannot say the exact moment in time when her heart stopped beating.
I do not. Well, based on her time of death, is what I would say.
When her heart stopped beating. You don't know that exact time, correct?
I think it's the same time as her time of death. That's how we pronounce death, is by no heartbeat.
And so then, the time of when her breathing stopped, you can't say that with certainty either, can you?
I can't recall if there's a documentation of no respirations after she got the medication. I'd have to review the medical records to see that, but I'm assuming that both of those things stopped around the same time.
And that's your testimony today? That you would
As far as I know right now, but I'm happy to, if you show me something that counters that, that's fine.
Okay, well, let me ask you this, because I know we talked about accuracy and completion, being complete. In any of your patient summaries, do you include the time when the patient's heart stopped beating?
When a doctor...
Yes or no?
The time of death is the time that we feel no pulse, and therefore the heart is stopped.
In your report, do you include the exact time when the breathing stops?
They're both considered the same time, so no. The time of death is my assumption of breathing and heart stop. That's as close as I can get it to accurate.
So the only time you include is the time that's entered into the computer.
Right. I wasn't there, so I have no availability at any other time.
I'm going to go to the next page. Danny Millett. Oops. Sorry, members of the jury.
That's more of the stuff for the individual.
Mr. Millett comes into Mount Carmel West already intubated.
Okay.
Is that correct?
Yes.
Okay. He has the situation at the rehab facility. He's intubated before he even gets to Mount Carmel. Is that correct?
Yes.
And he's on high doses of vasopressors. And even before getting to the ICU, would you agree that he codes multiple times?
Yes.
Codes, cardiac arrest, actively dying. Correct?
You keep making those things in the same sentence, but it's not necessarily. That's why we code somebody, is to prevent them from dying. But
Right. And a code is cardiac arrest.
yes.
Which means I'm in the process, right?
Of dying, we want to intervene and stop.
And you want to save me.
Yes.
Okay, so if I'm in cardiac arrest and I live, I've been saved. Right?
Correct.
And you indicated on your direct that this was a quote-unquote sick man.
Oh, yes.
Very sick.
Very.
And had just prior to this hospitalization, had 2 other surgeries within just the last couple of months, one of which was an amputation of a toe, correct?
Yes.
And when when we talked about how sick he was, he had had prior bypass surgery, he'd had a stroke, right? He had aortic valve disease. Would you agree with me that he had a number of ailments?
Yes.
He was also in the records noted to be obese.
Yes.
And I only mention that for tolerance issues, not for any judgment purposes. That makes sense, right?
Yes.
His GCS score was noted as a 3.
Correct. And that's why I pointed out above it says stuporous in 3.
You mentioned in your report and on direct that he was opioid negative. Do you remember that?
I can't remember each person I said that in, but if at the time I said that, it's based on my assumption, yes.
And I agree that you've only reviewed the patient file with respect to their last hospitalization, correct?
Yes.
But you certainly knew from his records that he had recently had an amputation.
Oh, sure.
And we can presume, based on your training and experience, that when someone has an amputation, they're likely to receive pain medication. Would you agree with me?
Yes.
And we know that he'd also had another recent surgery, correct? That was in his medical records, right?
Right.
And that he was at a rehab facility when he went into arrest and had to be intubated.
Right. I just didn't have any documentation of what he had been receiving, so I had no awareness that he was receiving high doses of narcotics prior to this.
Okay, but did you even include anywhere in your report that he had the prior surgeries and information wasn't available, but could impact your final opinion in this case?
Well, his right great toe amputation I do mention, and the report summarizes his current stay. So that's what I limited it to in terms of this summary.
And I want to go here, going back to the GCS that's documented as a 3. He's at a 3, is he not, for 7 hours?
Right.
13:45, he's a 3. 16:27, he's a 3. 20:45, he's still a 3, right?
It's a great point. That's exactly what makes number 6 so relevant, that he wasn't justified to give him any more medications if he's already in a sustained coma. You're making my point.
I want to go to Danny Millett's code sheets. Sticker, please. Sticker when you get a chance. As I've done with every patient, showing the witness what's previously been marked as defendant's Eli 15. Patient name on these code sheets?
Danny Millett.
And I want to just flip through them. Just generally, code sheet,
Yes.
heart rate sheet. Do you agree with me on that?
Correct. Yes.
Okay. Code sheet,
Yes.
heart rate sheet,
Yes.
code sheet,
Yes.
code sheet,
Yes.
heart rate 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 sheet,
No.
oops, code sheet,
Yes.
heart rate sheet,
Yes.
code sheet,
Yes.
code sheet,
Yes.
code sheet,
Yes. These are done at 2-minute intervals, so we often have much paperwork.
code sheet. 2-minute intervals, every code, a new code, right? Correct? Is that a yes for the court reporter?
If you put it back up, I can tell. Are those all individual codes, or was it consistency? Was it the code sheets of one
Sure.
code?
Let's go through it. Date, 12/5/15, right?
Yep.
Okay. Survived, transferred. So, did you see that?
Yes.
12/15/17, 11:48. Do you see that?
Yes.
Okay. That one's not marked, right?
Right.
It's to the survival.
So it goes to
this one. This is 1148, so that is a duplicate. Oh, I'm sorry, but when I say duplicate, the times are different, right? He's coding, and the times are changing. Do you see that, doctor?
Yeah, but it's the same code, isn't it?
It's the same code. 1151 going on.
I interpreted this to be all the same code, just continuation of sheets, because you're...
Stop.
1 second. Go. Okay, so going here.
New code.
That was new code. That was one code that lasted the span of several hours.
I don't
2 hours at least. Here, let's go through it. 1151, does that appear?
Yes.
Okay. And I'll just show this for a point of reference. We're going 1210.
Okay.
Same date, same time. 12:30. I'm just using this to show a period of time.
Okay, yes.
Okay? Then, give me 1 second. Okay. 12:30, same code. All right, and then now we have at 12:49, right? So that was
Right.
12:30. Now we have 12:49.
Right.
Right? Different code.
Right.
Okay. Different heart rate sheets, correct?
Okay, yes.
Okay, and the time listed here goes to 12:56.
Sure.
Does that seem correct?
Yes.
Okay, and then it goes on to 1321,
Right.
1329.
Right.
Okay, and this is the same, he's coding this whole time.
Right.
And 1332.
Right.
And then it notes resuscitation ended 1333, correct?
Right.
Okay. So, with respect to same issues that you noted with Danny Millett on the pain score. But you would agree with me that the medical records speak for themselves, right? You have no evidence that anyone's manipulated or changed any of these medical records.
I do not know that, yes.
So with respect to Danny Millett, not included in your report, nor can you say to a medical degree of scientific certainty the exact time by which Danny Millett would have survived but for the fentanyl.
Yes, I could never know that about anybody, about any human being.
I want to follow up. Did you ever see the death certificate for Danny Millett?
I don't recall seeing that death certificate.
I ask you this because I think with respect to the last patient, you mentioned that death certificates are oftentimes over-inclusive.
I didn't say over-inclusive. I said as inclusive as we can be.
Okay. I'm showing you what's been marked as Defendant's Exhibit DM2.
Yes?
What appears to be this individual's name?
Danny Millett.
Okay, and does this appear to be a death certificate?
Yes.
And if you see on the Defendant's Exhibit DM2, cause of death is indicated as what?
Sepsis and bacteremia.
And death certificates. Those are signed by the attending physician?
Yes.
The attending physician who has the benefit of reviewing the entire record?
Right.
And signing off on the discharge letter?
Right.
I'm going to go to Brandy Mcdonald here. One moment. is the patient who had ovarian cancer, correct?
Yes.
And the cancer had spread, had it not?
Yes.
In your report, I know that you had mentioned that she had deteriorated overnight and was intubated in the ICU, or in the ICU, correct? Okay.
Yes.
Did you note in your report that in fact it was Dr. Husel that intubated her?
No.
And intubation would be considered by you as an aggressive support measure?
Yes.
In your report, you indicate that there were additional curative measures which had not been exhausted prior to her extubation, and then you testified to that. Do you remember that?
Yes.
You're aware, are you not, when you reviewed the record, that Ms. Mcdonald had an attending physician at Mount Carmel West?
Yes.
And that's Dr. Chan. Do you remember that? Mm-hmm. And in the medical records, was there not a significant amount of record keeping as to the discussions that her attending physician also had with her GI doctor and her nephrologist, correct?
Yes.
And also discussions that her attending physician had with the ICU team.
Yes.
The word team was used.
Absolutely.
Correct? So discussions with the GI, the nephrologist, and the ICU team. And didn't her attending physician then note after all of those discussions that the patient's condition was, quote, critically ill and poor prognosis?
Yes, absolutely.
Nowhere in the attending physician's note does it say that additional curative measures should be pursued, correct?
I did not see that stated.
And you haven't spoken with the attending physician?
I have not spoken with that attending physician.
If you could please let her finish the question.
Okay.
You indicated that a palliative extubation is never an emergency. If you were the patient and and you're on vet support, and I am your designated power of attorney, it is true that I speak for you when you cannot speak for yourself, correct?
Yes.
And if I know as your power of attorney, as your sister, as your wife, whatever I am to you, that you do not want ever to be on a vet, and I make the decision for you to withdraw all life support saving measures, that might seem like an emergency to me, right?
The word emergency, I'm thinking about a code, like people running down the hall.
Because there is something, is there not, as someone that has worked in palliative care, where I, as your power of attorney, might, in your best interest, want you to die without all the tubes in you.
Oh, yes, absolutely. I think the distinction here is urgent versus
Okay, well, I will
emergent.
stop. Next question.
And I asked you that specifically with respect to Ms. Mcdonald, because her family, and I know you reviewed the medical records, was very clear. She would never want to be on a vet.
Right.
Never.
She should be taken off the ventilator.
With respect to Ms. Mcdonald, in your report. Fair to say that you do not include, nor can you have an opinion with a reasonable degree of medical certainty as to the time that she would have died but for the fentanyl.
Right, I would never be able to tell that.
Where is that? Were you ever shown Miss Mcdonald's death certificate or provided that information in the file?
Can I go back and add an answer to your last question?
No, you're kind of stuck here.
Okay.
With respect to her death certificate, her being Miss Brandy Mcdonald, did you ever receive her death certificate to your recollection?
Not that I know of.
Okay. Showing you what's been marked as Defendant's Exhibit BM2. Does this appear to be Brandy Mcdonald's death certificate?
Yes.
Okay. And if you could see at the bottom, what does it appear to be noted as the cause of death for Miss Brandy Mcdonald?
Hepatic failure, metastatic ovarian cancer.
And hepatic failure is noted as days, is that correct?
Right.
And again, with respect to Brandy Mcdonald, death certificates are filled out by the attending physician.
Yes.
And after they have the opportunity to review the patient file and do the discharge sheet.
Right.
Turning to James Allen, if we can. I have the portion of your report up there for you to refer to if you need to. Just want to talk about Mr. Allen a little bit. He was an 80-year-old, correct, smoker with dementia. Is that right?
Right.
And I want to talk about the conditions that he had prior to what you describe in paragraph 8 of your report. So he had COPD, correct?
Yes.
He had cardiopulmonary arrest,
Yes.
acute hypoxic respiratory failure, suspected due to be a GI bleed, right?
Yes.
He had atrial fibrillation,
Right.
acute kidney injury,
Yes.
kidney failure, right? Septic shock,
Yes.
and then chronic systolic heart failure with EF 10 to 20%. Do you remember that note in the file?
Yes.
And a normal EF, is it not, is between 50 to 70%.
Right.
So, and he had 10 to 20%, normal is 50 to 70%, right?
Right.
And doesn't that mean that the blood isn't effectively moving throughout the body?
It means that he has heart failure, yes.
Blood goes more slowly than it might if he didn't have heart failure.
Right.
And then he had this aspiration pneumonia due to the vomiting, right?
Right.
And his vital signs were noted as not stable.
Right.
And then when he's intubated, he's noted to be very critical. Correct?
Yes.
And the code blue is called and he goes into code. Would you agree with me on that?
Yes.
It's noted in his file, and I'm sorry, but he also gets CPR, right?
Yes.
CPR, you mentioned something that I want to circle back to on your direct. CPR can break someone's rib, can
Yes.
it not?
Yes.
Potentially more than one rib could be broken.
Could be.
And that's just as a side effect, if you will, of doing the chest compressions.
Yes.
And potentially, having a broken rib could be painful.
Although they documented a pain score of 0.
That's not my question. My question is potentially
Potentially.
You give me CPR. I'm done. You bring me back. And I have one broken rib. That could potentially cause me pain, right?
Yes, it could.
But your intention, double effect, is to save pain, right?
Right.
That's ridiculous.
You mentioned, let me just stick. You mentioned the absence on other cases of notations about the pain visual cues that were being received. In this patient's chart, it actually indicates that he's grimacing, right? That he's experiencing pain.
He did have some of that, yes.
And then it notes in multiple occasions that the grimacing then he's grimacing and he's having withdrawals. Do you remember that at 2050?
He's not having withdrawals. It says he withdraws. It means he withdraws to pain. You're confusing the circumstance. They're trying to cause pain. So he withdraws and grimaces to pain when they stimulate him.
Okay, so somebody grabs his arm and he withdraws.
If I squeeze his nail bed or something like that, he'll manifest a sign of pain. But their actual pain scale did not indicate in the absence of doing that he was in pain.
Not my question. The documents indicate that he's grimacing and that when he's touched in some way, he withdraws, right?
Not that he's grimacing. I'm sorry for the subtle difference, but that he grimaces if I cause him pain.
I understand because he feels.
Yes.
He feels.
Yes.
Right? With respect to, can I have a sticker? Before the fentanyl is ordered in this case, just as I've done with the other patients, and this time, James Allen, showing the witness what's been marked as Defendant's Exhibit Ely 16. On 5/28, it appears at 9/10, he coded. Is that correct?
Yes.
Okay. And this is, the code goes on, same date?
Okay.
And there's no, it appears, heart rate sheets to this. Does that sound accurate?
Yes.
Okay. And here it notes that he survived.
Right.
And that's in the ICU.
Right.
In Mr. Allen's medical records, I trust that you reviewed the notes that Dr. Ralston made.
Yes.
I'm sorry?
Yes.
And Dr. Ralston, not Dr. Husel, right? Dr. Ralston had extensive conversations with Mr. Allen's son. You remember that?
Yes.
And discussions about end of life, and the records indicate, do they not, that the son was quote unquote realistic about his father's limited reserve and end of life issues.
Right.
And that's not a Dr. Husel note. That's a Dr. Ralston.
That's right.
He's having a conversation with the family.
Yes.
About palliative extubation and a likelihood that Mr. Allen might or might not survive, right?
Right.
Okay. And it's then that the medical records indicate, do not, that the patient's family goes to the nurse and says, we want to withdraw all life support saving measures. The nurse then goes to Dr. Husel.
Right.
Right?
Yes.
So the family initiates that procedure with respect to Mr. Allen.
Yes.
Were you shown the death certificate with respect to Mr. Allen?
No.
Showing you what's previously been marked as Defendant's Exhibit JA2. Does that appear to be the death certificate from Mr. James G. Allen?
Yes, it does.
And just so orient, because I know it's a common name, age appears to be 80?
Yes.
And the causes of death that are noted by the attending physician in the death certificate, if you could read those to the jury.
Septic shock, Pseudomonas septicemia, and cholangitis. Days.
And obviously, not one of those causes is the fentanyl.
And you would never see fentanyl listed there.
But the attending physician didn't list it.
And they would never do that.
Can you show me that? Thank you. Because it reminds me of Defendant's Exhibit RH2, where fentanyl is actually listed.
Because the patient came in with a known overdose of fentanyl prior to coming to the hospital, so they were listed.
Doctor, it can't be your testimony now that the overdose was caused by a known drug when he came in.
The difference between that particular death certificate and all of the subsequent death certificates is that this death certificate is including medications because the patient is an addict. So the person who filled out the death certificate knew they were an addict and included medications as part of the process of their dying. None of the other death certificates, and she'll go through all of them, I'm sure, do the same thing, will ever show fentanyl because it was something administered at the time of death, and none of us would ever include that on the death certificate. So that'll be a recurrent theme, that this one showed the drugs because it was part of their history of being an addict, whereas the other ones will not include a medication given to provided at the end of life. No physician would ever put that on the death certificate.
I'm going to pull another one while we are.
Well, I'm using never to admit to. I should take the word never out and say it would be highly unusual.
Okay, it would be unusual.
Yes. I should not use the word never.
Okay, I want to just go back to James Allen because I remember your testimony about likelihood of survival, and I want to make sure that we have the notes from Dr. Ralston, we have the family initiating the conversation, and then isn't there also in the medical records the note from Dr. Mahoney that reads, I quote, "Unfortunately, I'm afraid you will not survive this episode." Correct?
This hospitalization, yeah.
Yes. And Dr. Mahoney is separate and apart from Dr. Husel.
That's right.
Same thing as to James Allen. Thank you. There is no time of death in your report, nor can you say with any reasonable degree of medical certainty as to when Mr. Allen would have expired but for the fentanyl, correct?
Okay, I'm glad you. No, I didn't say correct.
Oh, yeah. Okay, great.
Yeah.
Is that in your report?
Yes, the time here, 20 minutes. Sorry, I did it again. The time here, 23:20 to 23:40, and I want to answer this more accurately, that there was no indication that this person would die that rapidly on removal of the life support, but for the fentanyl.
Okay, and that's not my question. I appreciate that was your testimony on direct. My question is distinctly different. My question is, here today in this court, based on having reviewed these medical records, you cannot say to a reasonable degree of medical certainty as to what time he would have died but for the fentanyl, correct?
I'm trying to process the question. Bear with me here. I think that he would not have died but for the fentanyl in this short of time frame.
Okay.
It's the big screen that you got to use to clear. Is that what you're trying to do?
Okay, yep.
Up there.
Yes, please. Sorry.
Maybe you can just do this.
I want to just go back,
Bottom line. This, right?
Push it.
if we can, just to clarify something. I know now you said it's unusual, but we also know that James Timmons was a polysubstance abuse, had a polysubstance abuse history, correct?
Yes.
Okay. Just want to, you would agree with me, yes or no, that the cause of death says recent cocaine and fentanyl use, correct?
And that's yes, and it's a super example of what I'm talking about.
Oh, and so I just, Timmons and Hayes have fentanyl in them, correct? Just a yes or no, in their death certificates, it says fentanyl in the
Yes.
drug users, does it not?
Yes,
Okay.
because it was their history.
And in the others, the attending physician that reviewed the entire patient chart, including the orders of fentanyl that Dr. Husel gave to every one of those patients. And that attending physician reviewed this file, went to write their discharge, filled out the death certificate, and found those causes of death.
Because those are the disease
Yes or
processes.
no?
Yes.
Troy Allison. I know it's a lot, but every patient deserves the same time and attention.
Absolutely.
So I want to be sure to do that. Troy Allison, 4 heart attacks and prolonged CPR. Would you agree with me?
Yes.
And cardiogenic shock, which required the vasopressors,
Yes.
and acute respiratory failure, which required the mechanical vent,
Yes.
correct? Kidney failure, liver failure, endocrine failure.
Right.
He had severe metabolic acidosis that was not compatible with life. His pH was a 6.53. Would you agree with me?
Yes.
He had cellulitis of the leg, suspected pulmonary hemorrhage, correct?
Yes.
And then he had the suspected GI bleed. It's Troy Allison.
Yes.
I want to talk about the notes in the file as to other doctors. Because any patient at Mount Carmel isn't in the ICU, isn't just seen by one doctor, correct?
Right.
Dr. Woodard, in the ER physician note, did he not, wrote patient in severe critical condition.
Yes.
Quote, emergent life-threatening condition, end quote. Correct?
Correct.
Quote, incapacitating systemic disease, end quote.
Right.
That's in the ER. And then we had Dr. Patel, do you remember that he had notes in the file as well with respect to Mr. Allison?
Yes.
And he wrote, quote, poor prognosis, correct?
Yes.
There were, in Mr. Allison's file, also chaplain notes, were there not?
Yes.
And I should have asked you this about the other files, but there's chaplain notes in a number of
There are.
files, right?
Very encouraging, yes.
And the chaplain is able, it seems, from the medical records, to actually have discussions, spiritual care individuals have discussions with the family, and then they enter in summaries of their discussions.
Yes.
And those are in here.
They are.
And separate and apart from the doctors and nurses, it appears they're actually entering in their own notes.
Yes.
And with respect to the chaplain note associated with Troy Allison's family, did it not say, quote, the family opted to withdraw the ventilation support, knowing this patient did not wish to be on life support?
Yes. Yes.
And the chaplain in Sandra Wilson, was the chaplain specifically, spent 150 minutes of death support with Troy Allison's family.
Yes.
Like 150 minutes total, right?
Yeah.
So that's over 2 hours.
Right.
Really spending time with the family and records to make sure that they understood the decision they were making and the impact it might have.
Right. That's beautiful care.
And yet on your direct exam, you testified, and I quote, let's keep him going. Remember saying that?
My point is to allow his natural dying process to occur, and I agree with the family's decision to support him and remove the life support. That's it. The decision to remove life support does not equate to determining death by giving drugs. There's a very important distinction there. So I support the family, I support the chaplain's note, and that family never asked for him to receive a lethal dose of medication.
Okay. My question to you is that on direct, you testified, I just wrote down the words, and tell me if you want to say these words in conjunction with one another. Let's keep him going.
Let's keep him going equal, allow him to die naturally. That's what I meant by that.
Okay, because certainly the family, over 2 hours with the chaplain, because that's not how Troy Allison wanted to live.
I do not think that the family has made it abundantly clear that Troy would want to have his life support removed, and that's critical. We have to do what the family wants. That's why we did a baptism in ICU, because somebody asked for it. But it doesn't mean kill them with a drug. There's a big, huge distinction.
How does the baptism, how did the baptism come in with Troy Allison? He didn't ask to be baptized.
I'm showing how we will go to any extent to try and listen to someone's end-of-life wishes and provide them the end-of-life dignity that they ask for, which in this case did not include a lethal dose of a drug. Nobody asked for that.
And so I go back. If Troy Allison had the power of attorney, because he can't speak for himself, and I'm the power of attorney, I speak for Troy, right?
Right.
I decide, because Troy has told me I have that power and that privilege.
Right.
I speak for Troy.
Absolutely.
Did you review the death certificate in Troy Allison?
No.
Showing you what's been marked as Defendant's Exhibit TA2.
Cardiopulmonary arrest, acute upper gastrointestinal bleeding, acute respiratory failure, and seizures.
Gastrointestinal, we call that like the GI tract, is that right? James Timmons. James Timmons, I know we just briefly showed you his death certificate. I say this not out of disrespect, but just to be factually accurate. Like Mr. Hayes, he had a history of substance abuse. Is that correct?
Right.
And I just want to talk about, I noted during your direct examination that you indicated that you didn't know how long he had been down. But actually, doctor, isn't it true that in the patient medical records, it indicated that he was found, quote, down for likely 48 hours? Do you remember that?
Yeah, I was kind of focusing on the word likely. I mean, I don't know, but yeah, it's an extended period of time, they thought.
I mean, 2 days? And then the note goes on to say that he's in the basement for 2 days. That's a long time, is it not?
It is, which evolved as compartment syndrome.
Okay, to be without a pulse. So I'm just curious, though, the 48 hours that he was down isn't included in your report, correct?
No.
And then he was placed on, and he was also found with a needle in his arm, right?
Right.
Okay. He was placed in immediate dialysis, was not. CPR was started, correct?
Yes.
Okay. And of course, you've noted his polysubstance abuse and cocaine abuse, which was noted in his patient file, right?
Right.
And he's given the maximum dose of vasopressors when he's in there.
Right.
Right, like trying to keep him alive.
Yes, absolutely.
And when he's even on 2 vasopressors, his blood pressure was a 78/46. Does that sound right?
Yes.
And I want to go back to that chaplain note again. Do you remember that the chaplain note in James Timmons' file, even that note indicated, quote, critical diagnosis?
Yes.
Have a second. And then Dr. Ralston, do you remember that name as another ICU physician? Different shift,
Yes.
but at Mount Carmel West. There's a Dr. Ralston ICU note with respect to James Timmons, is there not, 13 hours before he passed, he being Timmons, that said, quote, without the ventilator, vasopressors, and interventional critical care, the patient would die.
Right, correct.
And then Dr. Bastati, internal medicine note, 16 hours before Mr. Timmons passed, wrote, quote, high mortality risk. Does that sound right?
Yes.
I just want to show you what's been marked as defendant's exhibit. Eli 17, the code sheet on him, it appears 1022, 1848, resuscitation ended. Do you see that?
Yes.
And this sheet, 1022, resuscitation ended at 2:36 and recognized at 2:25. Oops, sorry.
Yes.
You see that? So these appear to be different code sheets. Is that fair to say?
Correct, yes.
And this one, this code sheet right here at 2025, can you tell me which physician's signature is on that code sheet?
William Husel.
So at 10/22/2025, William Husel is in the room in the ICU saving James Timmons' life.
Right.
And then tell me if you could, 10/22/2018, 2308. This seems like a third code sheet. Is that right?
Yes.
And again, so this is about a few hours later.
Right.
And again, tell me if you could, the physician's signature here.
Dr. Husel.
So again, Dr. Husel, several hours later, is in the room in the ICU while Timmons is coding and he's saving his life.
He's running the code.
I asked you those questions about Dr. Ralston's note and Dr. Bastati's notes because I wrote during direct examination you talked about maybe James Timmons could have walked out and had rehab and a life of recovery. Remember testifying about that?
Yes.
I want to talk to you about the note also that I think is not included in your report with respect to the patient's reaction to the fentanyl when it was administered. Do you remember in the medical records, the nurse Jake Deemer note as to how the patient responded to the 1,000?
No, I don't remember what she wrote.
It could have been a man, too.
Okay, good
The
point.
nurse, she, he,
Either one,
right?
yeah.
Before I get to that, though, I missed this with respect to Mr. Timmons' intolerance. We know that he has a polysubstance abuse issue, right?
Right.
And then he was intubated for 30 hours, and over that time, did he not, he got 6,200 micrograms of fentanyl. Do you remember that?
Yes.
In the medical records?
Yes.
So 30 hours, 6,200 milligrams. And so I mentioned that to you in your discussion as to whether he was opioid naive or tolerant.
I think he would not have been opioid naive and tolerant.
Can I have that document? statement document to show you. Because I think in the medical file, you would have not only reviewed what happened to Mr. Timmons in the ICU, but also the drugs that he was administered in the ER before he got sent to the ICU,
Right.
correct? So my question was about the 6,200 micrograms of fentanyl that he was given before the decision was made to palliative extubate. I want to pull a sheet to also show you what he was given in the ER. OR, sorry. Well, while we're looking for it, in evidence, we've introduced a document that says, with respect to Mr. Timmons, he was administered in the OR. So he was administered over 14,000 micrograms of fentanyl. If a patient order form indicated that, would you have any reason to disagree with that?
Well, the person's under general anesthesia in the OR on a ventilator, so they're going to give what they need to give, and they could receive that much on a ventilator. That's the key difference.
Oh, right. I was just adding the amount
Yes.
to the opioid conversation.
Okay.
Okay. And
I don't remember that number, but if you say so, I take your word for it.
okay. And also, I want to just go back to the chaplain conversation with respect to Mr. Timmons. There is a note that the spiritual care team and/or chaplain spent 90 minutes of what they call death support with the family. Did they not?
Yes.
Showing you what's been marked as Joint Exhibit 11, page 279. We just wanted to close the loop.
Okay.
So, indicates patient, would you agree with me, is James Timmons?
Yes.
And the order details, would you just agree that it's over 14,000 micrograms of fentanyl?
That's what it says.
Okay. We'll go to Rebecca Walls.
Hold on, before you go any further, counsel approach.
Go ahead and talk it up, guys. You gotta pull your part around here. Come on.
So we get updates maybe once a day. The last one was, they're just running a lot.
That's what I thought. I just wanted to make sure.
Okay.
Ready?
Yep, thank you, Judge.
I was talking to Sam, but
All right, let's go to Rebecca Walls. It's late, so we'll mix up the order of things. Rebecca Walls, fair to say that you indicated time of death was 1:32?
Yes, 5 minutes after she got the fentanyl.
Just want just want to point out, showing you what's been marked as Defendant's Exhibit RW2. Were
Right.
you provided this death certificate?
Yeah, no, I didn't see it before.
Okay. I note this because you mentioned 132 is 5 minutes after. Again, so we're clear, the death certificate is filled out by the attending physician,
Right.
who has the opportunity to review the entire patient medical record.
The diseases that they have, yes.
Right, and then fills out the discharge summary and closes out the file, right?
Based on the diseases the person has.
The time of death is listed as 021 here, is it not?
Yes.
30 minutes after one.
I don't know which one's accurate.
In Walls, Chaplain Notes, Rebecca Walls, the Chaplain Notes indicate that 180 minutes were spent with the family. Does that sound about right?
It's beautiful.
Sound about right?
Yes.
And you mentioned on your direct examination the cover of darkness. Things were done under the cover of darkness. You remember that expression?
Yes.
There's nothing cover of darkness, if you agree with me. In fact, you said it was beautiful, that the spiritual care team is there with the family at night for 180 minutes.
That is true.
And you know, do you not, that in the ICU unit at Mount Carmel West, the lights are off. It is not dark there, right?
It depends. We turned the lights down quite a bit at night. I wasn't there to see the lights, but it was a figure of speech, not literal.
I'm sorry. One moment. One moment. Okay. So 180 minutes with the family. And we know from the other patient files that the spiritual care team chaplains are there, right? So this isn't, you're familiar with the expression like a lone wolf, right?
Yes.
But this is, we have nurses, we know from the patient files. We have nurses, right? We have charting nurses, right? We have chaplains, spiritual care people, all these people there in the ICU for any one of these 14 patients. Would you agree with me?
Yes, I agree with you.
And we're not sure about the dimmer switch, but we are sure that in the ICU, the lights are not off. Would you agree with me on that?
I have no idea. We turn the lights off all the time in the ICU at night.
Oh, okay.
It really is dark up there a lot of times.
So Rebecca Walls. Miss Walls was at Mount Carmel West for 6 days, correct?
Yes.
And she had cancer as well, did she not?
She did.
Okay. And I just want to kind of go through her multiple acute diagnoses included acute respiratory failure requiring the mechanical ventilation, correct?
Right.
She had the cardiogenic shock requiring 2 doses of 2 times she got vasopressors, correct?
Correct.
She had the kidney failure.
Yes.
The acute blood loss anemia, which required multiple blood transfusions, correct?
Yes.
She had congestive heart failure.
Yes.
Severe aortic valve stenosis, correct?
Yes.
She had had a stent replacement due to aortic issues previously, correct?
Yes.
She had edema.
Yes.
And she had metabolic acidosis.
Yes.
And I want to talk about what other doctors, not Dr. Husel, what other doctors wrote within Rebecca's patient file. Because I noted on direct, you said there was no evidence she was dying. Do you remember that testimony?
Yes.
Okay, let's go to the note that Dr. Wadakati, and I might be saying that wrong, it's W-O-I-D-T-K-E. The internal medicine physician note, 17 hours before her death, said, and I quote, critically ill, prognosis guarded, she looks very ill. Do you remember that note from Dr.
Yes.
Wadakati?
Mm-hmm.
Then Dr. Closer, C-L-O-S-S-E-R, in the ICU day shift, wrote, did he not, consult palliative care, poor diagnosis. I don't don't think she's going to survive. Remember
Right.
that?
Yes.
And then there's also Dr. Riley's, the nephrologist physician note. Do you remember that?
Yes.
So we've got lots of doctors looking, eyes on Rebecca Walls.
And everybody is agreeing, yes.
Okay, everybody's agreeing that he writes, Dr. Riley, 13 hours before the decision to palliatively extubate her, she remains ventilator and vasopressor dependent, now with increasing lactate, an ominous sign, especially on dialysis. Do you remember that note?
Right.
All notes separate and apart from any observation Dr. Husel makes.
Yes.
And this is another one of those cases, is it not, Rebecca Walls, where actually it's the family who goes to the nurse saying, our loved one, Rebecca, would never have wanted machines or to be resuscitated. Do you remember that?
Right.
And the chaplain wrote that note in the records, right?
Right.
And we can presume, just like any note taker, that when someone writes things into the electronic medical record, they do so, that's the record speaking for them, right?
Yes.
Okay. And then they notified Dr. Husel. And in that case as well, at night, 180 minutes of death support is, as we discussed, not with the family, right?
Yes.
And I'm just adding up the amounts of fentanyl she received in her time at Mount Carmel. It looks like she was there for 4 days, and before she was palliatively extubated, she received 4,800 micrograms of fentanyl. Does that sound right to you?
Right. So that's a very low dose in comparison with what she got at the end of her life.
About 1,200 a day, if I do my math, on average.
Right. So very low in comparison to a dose, nowhere near a dose of 1,000 micrograms in one dose with midazolam and other drugs on top of that.
And Rebecca Walls was 75.
Yes.
James Timmons? We did. Paula, don't hurt me, but I don't, it's hard to keep track of the report. Let's talk about Bonnie Austin. Bonnie Austin was 65 years of age. Does that sound right?
Yes.
And this is Bonnie Austin was the 600, just so we can orient ourselves, right?
Okay.
Okay. We haven't talked about patient-specific, but and what that means, but you would agree with me that patient-specific is you determine the appropriateness of medication based on the patient's history, right? Which could include tolerance, comorbidity, prior health conditions, etc. Right?
Correct. And their response to the medication.
And their response to the medication. Conditions with respect to Bonnie Austin, acute conditions. She obviously had respiratory arrest, correct?
Yes.
She had cardiac arrest after the EMS arrived, did she not?
Right.
And then she had 5 more.
Right.
And CPR was required on her.
Yes, and she had her chest tube to fix that problem.
And did you note also that she has stage 4 chronic kidney disease as
Yes.
well? Is that right?
Yes.
She has COPD, hypertension, correct?
Right.
And her pulse was 5 times by the time she was brought to the ICU. And it elevated 5 times as measured by the time she finally got to ICU unit at Mount Carmel West, right?
Right. When your lung collapses, your pulse is going to go through the roof. Yes.
It was like sky high, right?
Yeah, sure. That's a good response, an appropriate response.
And the chaplain note with respect to Bonnie Austin said, and I note the chaplain note, it said, quote, she was actively dying. Did it not?
I don't remember that note. Can you put it up there?
Sure. Bonnie Austin. While he's doing that, her blood pressure, oh, I'm sorry, and even then, Dr. Tom Brady further says, quote, she's actively dying. Do you remember that?
Yes.
And Tom Brady was one of the doctors that had eyes on Bonnie Austin at Mount
Yes.
Carmel West. And I think this is, Bonnie Austin was the one where her blood pressure, she's extubated, vasopressors are turned off, and the blood pressure couldn't even be recorded because they couldn't even get blood pressure. Do you remember that?
Right. That's not unexpected when you have a collapsed lung.
And so her respiratory rate was noted as a 5, and her pulse was a 39. Do you remember those notes?
Right. But in my memory, those things were fixed once her chest tube was placed. She had an acute fix of the chest tube of the collapsed lung, and then those vital signs corrected themselves.
Okay, tell me if she's extubated at 2330, the blood pressure issue that I just mentioned, your belief would be that it's before that. Is that right?
It may have occurred again, but initially her vital signs were corrected with the chest tube. I thought that's what you were referring to.
Yes.
Maybe you were referring to a different time.
Yeah. Yep. Okay. I'm finding the Tom Brady, the doctor and the chaplain note.
Okay.
Just give me 1 minute. When I say I'm finding.
Yeah.
Clearly not. Showing you what's been marked as Defendant's Exhibit Ely 18. And these code sheets appear to be related to Bonnie Austin. Is that true?
Yes.
Okay. And 9/13/18, CPR 19/18. Does that seem correct?
Right.
Okay. And this goes to 1959.
Yes.
And then there appears to be a heart rate sheet. And it goes on, it appears to 2028.
Okay, yes.
Heart rate sheet. And it appears to go on to 2047.
Yes.
Heart rate sheet. Is
Yes.
that correct? And it's noted up here that she survived and she's transferred to 4H112.
Right.
Do you happen to know the floor of the ICU unit
No.
at Mount Carmel West? Showing what's been marked as Joint Exhibit 10, page 10. Does it look like that this history and physical sheet is authored by Tom Brady?
Right.
And it indicates that the reason for admission or chief complaint is what?
Oh, cardiac pulmonary arrest. But this note doesn't support, well, it doesn't agree with what you said earlier.
I'm sorry, what?
I thought you said earlier that his note prior to her being taken off life support was that she wasn't doing well. But this one is after she's already removed and received the fentanyl. It says she's having agonal respirations, but it's after the ET tube has already been removed as part of the care de-escalation. So that's a comment about what she would look like after she'd received the fentanyl and was taken off the life support, is the way I'm interpreting that.
Okay, so I'm looking at this note right here. Is when I examined the patient, the ET tube had already been removed as part of the de-escalation and comfort measures, right?
Right.
She was having agonal respirations and had no heartbeit.
Right, because
Right.
she was given 600 of fentanyl, and then those medicines stop her heart and her rebreathing to some degree.
Let me ask you this then. So we have another doctor laying eyes on a patient that knows she's been given 600.
He didn't say that he knows what she's been given.
Well, he says he examined the patient
Yeah, but
after
that
the tube has
doesn't-
been removed, right?
Yeah, but I walk in a room all the time, and I don't know I don't always know what somebody just received before I walked in the room. He doesn't tell you there that he knows what she was given.
Okay, but you know what he does say, though, is that she's struggling. She's having respirations, right?
She's having agonal respirations.
Right. And that's noted right there, right? And doesn't it also say the ICU team and chaplaincy are working with the family? She is actively dying, right?
It says the ICU team is chaplaincy are working. Yes, she's actively dying.
She's actively dying.
And that's exactly what somebody would look like if they were trying to breathe after having been given a medicine that would prevent them from breathing.
So this is a good point. So, because I just need to understand this. Dr. Husel ordered the 600, right? That's
Right.
on the order sheet.
Right?
And then Dr. Brady is bedside while the 600 is administered.
I don't know. I don't know when he got in there.
Yes, you do.
Okay, is that a question?
We have Dr. Brady coming in. He can talk about what was there.
Where's the number? Thank you. When I examined the patient, so we know he's in the room, as part of the de-escalation and comfort measures, right?
Right.
And this is a Dr. Brady note.
Yes, this
That's
is
just my question. It's Dr. Brady that's
It's a
writing
Dr.
the
Brady
note?
note. Yes.
Bonnie Austin, showing you it's been marked as Defendant's Exhibit BA2. It appears Bonnie Jean Austin. Would you agree with me on that?
Yes.
And time of death is noted as 23:53.
Yes.
And the reason that the listed reasons, causes of death, immediate and otherwise, are listed as what?
Tension, pneumothorax, and COPD.
I want to show you what's been marked as Joint Exhibit 10, page 6 through 7. Does this appear to be a record, a discharge summary with respect to Bonnie Austin?
Yes.
And does it appear to be signed by Thomas Brady?
Yes.
So we can assume that because he's doing the discharge summary, he's her attending physician.
That's right.
Correct? Is that right?
Yes.
Okay. And he writes here, does he not, there's a list of acute final diagnosis.
That's right.
And as part of the discharge summary that Dr. Brady wrote, it includes the vent withdrawal time,
Yes.
the time of death,
Yes.
and then it also includes, does it not, the medications that she is given, as well as a summary.
Yes. Can I see the list of medications?
Sure.
Where's the fentanyl?
Oops, sorry. Let me scroll it up. Can you give me page 8, please? It's what? Do you see that? And let me go up here while we're getting that. COPD was brought. This is a summary right here, correct?
Right.
And history was taken from the chart. The last sentence says the family has decided to de-escalate care.
Right.
And the time from the vent withdrawal to the time of death is what?
About 25 minutes.
And actually, you know what I'm realizing, Dr. Ely? These are medications that that she was prescribed prior to coming to Mount Carmel West.
Okay, because that's the point, is that I don't see any documentation in a single medical record of any other doctor saying that they were aware of how much fentanyl these people were getting. That's the big mystery. Nobody has said to me, I know how much they got, except for Dr. Husel. So that lone wolf thing kept coming to my mind, actually. Like, is he the only one who's paying attention to the fact that he's given them these large doses and they don't know?
Okay. So, and I know we've covered what a discharge summary is, but you would agree with me that right here, Dr. Brady writes, history was taken from the chart, right?
Yes, but that does not mean that he knew how much drug she was given.
Okay. In the patient's chart, is a medication order form?
Yes.
Okay. Is a MARS, a medication administration?
It's all there, but it just depends on if somebody might not review them to do the discharge summary. If the person has a straightforward cause of death and they think, oh, this is the emphysema, they're not going to go search all the MAR to see the exact doses they were given at the end of life, because nobody would ever expect for somebody to be getting this much medication. So you wouldn't even go looking for that. It would just be so out of your head as a possibility.
It's the last medication, and you would agree that you're not the attending physician on any one of these cases, correct?
That's right.
And you didn't talk to Mr. Brady nor any other attending physician.
Right. I'm looking for evidence that they knew how much they were getting, and I don't see any.
Well, the nurse knew when they administered it.
They did.
Okay. And on the orders that were verified by the pharmacist, they knew.
Objection. I'm not allowed to.
Okay,
I think
he's
that
on the floor. You're going to reiterate, sustain, rephrase.
Okay? Jeremiah Hodge. Thank you. This was the 57-year-old woman that came to the ICU, and she never regained consciousness, correct?
yes.
And you testified that she was unresponsive and in continuous coding. Does that
Can you
sound
put
familiar?
the sheet up there, please? Can I see the sheet?
Oh, sure. Can you print it for me, please? I've lost the report, so that's... just Jeremiah Hodge. We get it. Yes.
His report on that?
Thank you. Appreciate it. Team effort. Jeremiah Hodge. There we go. This is a 57-year-old woman. Does that ring a bell?
Yes, definitely.
And I think that you said on direct that she had a big bad heart attack. Do you remember saying that?
Yep.
Okay. And just again, marking this. Jeremiah Hodge, 4/1/18/2108. Her code sheet. Marked as Defendant's Exhibit Eli 19. Code sheet 2108 went on to 2114. Does that look about right?
Yes.
Okay. And I want to make sure it's not that clear, but the
Okay.
physician's signature, and if you can't make it out, I certainly would blame you.
I'm assuming that's Dr. Husel.
Okay. And certainly, would you agree with me that 2108 is generally a night shift time?
Yes.
Just want to go through with respect to her conditions. She had lost her pulse several times, correct?
Yeah, can you put the sheet back up there, please?
Yes, the sheet needs to be there. Oh, nope. Give me 1 second. How's that?
Yeah, that's helpful.
She was found by the EMS to be, how do you say that? Asystolic?
Asystolic?
Asystolic, right? And she
Yes.
was still that way when she got to the emergency room.
Right.
It's the most serious form of cardiac arrest, is it not?
Right.
And the EMS was doing CPR, but they couldn't get her pulse back. And again, she never regained consciousness. Is that correct?
That's right.
Okay. And with respect to just the measures to consider, that she was noted to be obese,
Yes.
and she had 5 organ system failures,
Right.
had lactic acidosis,
Right.
and low pH. Her level was 6.73,
Right.
and 7.4 is normal function. Correct?
That's right.
She had acute respiratory acidosis, had acute kidney injury as well, right?
Correct.
She had anemia,
Yes.
elevated white blood cell count, and a number of other issues. Is that correct?
Yes.
She also had diabetes. I just note that. Is that
Yes.
right? It is noted, was it not, in the file that she, not by Dr. Husel, that she had, quote, a poor prognosis and was in critical condition. You would agree
Right.
with me on that?
Right.
And Dr. Husel, if you recall, is the one that actually starts CPR on her when she's in the ICU. Do you recall that?
Yes.
And he increases the vasopressors from a 20 to a 50.
Right.
So when you increase the vasopressor, would you agree with me that you're trying to help someone and not trying to hurt them?
Yes.
Tell me why, and I mentioned the diabetic, because someone being a diabetic is an important factor to consider when generally determining the appropriateness of the medication. Is that correct?
Yes.
Showing you what has been marked as Defendant's Exhibit JH2. Does this appear to belong to patient Jeremiah Hodge,
Yes, it does.
age 57, just to
Yes.
reconcile it? And as noted on the death certificate, the causes of death are what?
Multi-organ failure, cardiopulmonary arrest, and diabetic ketoacidosis.
And what's ketoacidosis?
That's just when your diabetes goes awry and you built up a lot of acid in your blood.
And that indicates the interval time on that is indicated as day, and the other 2 is hours. Would you agree with me?
Yes.
We have 3 more. I see the finish line, and I know your flight. But it's also important. Francis Burke. Just want to get your reports. You have it. Francis Burke was, and I'm getting it, Doctor, 73 years of age. Does that sound familiar?
Yes.
And as I'm pulling that, before 6 months before she came to Mount Carmel West on the most immediate hospitalization, she had a pulmonary embolism, had she not?
Yes, she had.
And she is also, in her medical records, noted as obese.
Yes.
And the notes indicate that she had a devastating intracranial hemorrhage
That's right.
and acute respiratory failure.
Yes.
Is that right?
Yes.
Show you what's been marked as Defendant's Exhibit FB2. Does this appear to be the death certificate of Francis Burke?
Yes.
Okay. And kind of to just state it, fair to say she just had a brain bleed? Is that a common way to say it, Doctor?
Yes, she had brain bleed.
Okay. Because of the fancy words, I just want to, the visuals, she had a large intracranial hemorrhage means she has a brain bleed, right?
Right.
And don't the medical notes indicate that or rather, let me ask you, that the brain bleed was so bad that it can cause one side of the brain to press on the other side of the brain, which can cause death, right?
That's right.
Her death certificate here, causes of death, if you could just read those that are listed on the certificate.
Right. Acute intracranial bleed, oral anticoagulants, and pulmonary emboli.
What are anticoagulants?
So what happened was she got a blood clot weeks, I don't know exactly the time, but sometime remote from this. She needed that treated with a blood thinner to allow the body to break down that clot. That's an oral anticoagulant. It's something that makes your blood thin. In this case, the drug, the oral anticoagulant, caused a bleeding problem. So instead of doing just good for the blood clot in her chest, it actually created bleeding in her brain. And that's a good example of why a drug is included on these sheets. In this case, it's part of her disease process. The drugs won't be included if they're later in the process, necessarily.
And I mentioned the pulmonary embolism that she had 6 months prior. That's noted on the death certificate, is it not?
Yes.
And it just says emboli?
Yes.
Okay. And there's no time associated with either of the anticoagulants or the embolism?
That shows the inaccuracy of people filling these out. There should be times there. It's just a mistake.
Well, and your report has some mistakes in it, because people aren't perfect, right?
That's right.
I want to just show you what's been marked as Joint Exhibit 6, page 13, with respect to Ms. Frances Burke.
Excuse me. No, damn it, I'm sorry there.
Just talking about her current condition, would you agree with me that the author of this progress note associated with Frances Burke appears to be Dr. Wooten?
Yes.
And we know that she expired on 1/14/2018, correct?
Yes.
Okay. And this note appears to be the day prior.
That's right.
And I just want to go through it with you that Dr. Wooten is indicating that he had a family meeting with the husband and multiple family members, correct?
That's correct.
And he showed them the image of the CT, so of her head, did he not? And explained the findings that neurology believes there's nothing that can be done for her.
That's correct.
And the words say not salvageable.
It does.
In the very small chance that she were to survive this, the potential of complete neurological recovery is essentially nil. Right?
Right.
And doesn't it appear from his note that this is information that he's sharing with the family?
It does.
And he goes on to say in his charting, I emphasize to them that the massiveness of the stroke will ultimately lead to a brainstem herniation, which will cause her to go into cardiac arrest, leading to further neurological damage.
Right.
And neurological damage is more brain damage, right?
That's right.
And then lastly, the family does not want the patient to receive chest compressions, which you know she would not want, especially since they understand that her condition is irreversible.
Correct.
Correct? And that's on 1/13/2018.
Right.
Showing you what's been marked as Joint Exhibit 6, page 181. The next day on 1/14, when the 1,000 micrograms of fentanyl is administered, I just want to note, and again, I know your ongoing testimony with respect to 10s, but the pain score is noted by Nurse Dreyer to be a 10. Am I correct?
Yeah.
I'm sorry, what was your answer?
Yes.
Anything else on that? Sandra Castle. Just need the report. Sandra Castle, here's your report.
Okay, thank you.
80-year-old woman, correct?
Yes,
The conditions that she also had, I want to go through them because when you talk about sort of what the patient could have done or how she could have lived, she had systolic congestive heart failure, correct?
right,
Pulmonary hypertension.
yes,
She had stage 3 chronic kidney disease,
yes,
COP,
yes,
diabetes,
yes,
hypertension.
right,
The paramedics, as indicated in her medical file, had documented her ventricular fibrillation, correct?
right,
Cardiac arrest, right?
correct,
Cardiomyopathy.
right,
She also, again, in the medical records, it's noted that she's morbid obesity.
yes,
Her BMI was noted to be 45.
yes,
And then she had shock, likely cardiogenic,
yes,
and she was found unresponsive at home.
right,
Certainly, Ms. Castle doesn't come to Mount Carmel West as a healthy patient. Would you agree with me?
I agree.
One moment. Thank you. Showing what's been marked as Defendant's Exhibit S, as in Sam, C2. Does this appear to be the death certificate of Sandra Castle?
Yes,
And again, just to orient ourselves, age 80.
yes,
And it appears there's only one cause of death listed here, and what is that?
anoxic brain injury,
Anoxic brain injury.
right,
And it indicates duration of time, as indicated on the form, is days.
that's right,
Prior to the palliative extubation, Sandra Castle, in her time at Mount Carmel, had received 6,000 micrograms of fentanyl in 3 days. Does that sound accurate?
yes,
Okay, I've got to stop.
Okay.
If he's going to make his flight.
Okay.
Okay? Ladies and gentlemen, I'm going to excuse you for the day. I'm going to get the doctor on the road, so to speak. So we'll get started at 9 o'clock in the morning. We'll be doing it by Zoom. It's just as if you were on the stand to the best of your ability. You've had a chance to watch him here in the courtroom. We will see you in the morning. Remember the admonitions, David?
All rise.
Have a good evening, guys. I hope you guys got it set up for him. Yeah.
thank you, Judge.
Well, be available to